My name is Mark Frankle. I'm an orthopedic surgeon. I practice at the Florida Orthopaedic Institute. My education began at Grinnell College in Iowa as an undergrad doing pre-medical studies. I finished that in 3 years and started medical school as my 4th year of college, my first year of medical school. I did a year of research in medical school, and then I started my orthopedic residency at the University of South Florida here in Tampa. And then I did an adult reconstructive fellowship at the Mayo Clinic, and I also did a year of research in the Orthopedic Institute in Davos, Switzerland. And then I started my practice that specializes in the treatment of shoulder and elbow problems in adults in 1992. I've been doing shoulder replacements since 1992 and done close to 6,000 shoulder replacements. And those would be considered either total shoulders or reverse total shoulders or some other form of a shoulder replacement. My most recent accomplishment is that I have been elected by the American Shoulder and Elbow Society to be the president of that society. And that's a society of the best shoulder and elbow surgeons in the world. It currently has 1,000 members, and it starts out that I'm the vice president this year. Next year I'll be the president-elect, and in 2021 I'll be the president. And as the president, I preside over the annual meeting, which will be in Tampa because that's my hometown. And we'll have over 1,000 shoulder surgeons from around the world coming to that meeting to discuss the newest treatments, outcomes of shoulder and elbow surgery, and it will be quite exciting. So that's my most recent accomplishment that I'm really quite proud of. Other accomplishments is I've been training fellows to be shoulder and elbow surgeons. I trained my first fellow around 1996. And I think since that time I've trained about 50 shoulder surgeons. We now take 3 fellows a year and we get about 30 applicants a year, so again, fairly competitive. And of those people, we train them, they spend a year with us, and that's another great accomplishment because many of them have gone out on their own right and become really quite well-known and successful shoulder and elbow surgeons. When we look at outcomes of patients after shoulder replacement, we never give people a normal shoulder afterwards. We make them better. And part of the research that we've done for the last 30 years is trying to figure out an accurate way to represent outcomes that are something that we can measure in a way that clearly defines the effectiveness and maybe the limitations of the procedure. So we've come up with various different ways. And again, people are uniformly better. They have less pain, they have more mobility. Many people can go back and do many of the activities that they were unable to: golf, tennis, working out, many activities, but some of it is dependent upon the patient's own motivation and their skill set. But it's, you know, today I saw a guy who I replaced both of his shoulders, and he's an avid workout guy. If you saw this guy, you would never believe this guy's had a shoulder replacement. I mean, he's really muscular, and he's in his 60s, and he couldn't do that before. So that's an example. Just today I saw, and it's common, and that's what the goal of a joint replacement is. It's to improve patients' quality of life so you can be active and you can achieve some of the activities that your arthritic condition limits. The difference between an anatomical shoulder replacement and a reverse shoulder replacement, again, the idea is when the muscles are good and the joint is worn out, much like you might wear out the tired treads in your car symmetrically, then replacing that joint with surfaces that match up, that's when you would use an anatomical replacement. In cases where, again, your treads might be riding off way to one side, so they're asymmetrically worn, that's when a reverse shoulder would be considered. And the parts are very similar looking, except where the ball is normally, that's when you would do an anatomic ball, and on reverse, you have a socket there. On the socket side with an anatomical replacement, you replace the socket with a socket, where in a reverse, you replace the socket with a ball. Our normal shoulders are amazing in terms of their ability to provide motion. That is the hallmark of shoulder joints as opposed to hips and knees. They have an extensive amount of motion, allowing us to throw, allowing us to reach behind our back or on the back of our head, to do other activities such as strength activities over our head. And it's that combination of mobility, stability, and strength that separates the shoulder joint from all the other joints in the body. And in order to replace a shoulder, it's important to understand, well, what is the mechanical problem that the patient is trying to resolve? And the mechanical problem often is the source of the complaint. So patients don't come to me and say, I have an arthritic shoulder. They say, my shoulder's painful, and I no longer can reach the back of my head, or I no longer can use my arm to paint the house, or I can't sleep on my shoulder because it wakes me up at night. And then when you examine someone with an arthritic joint, you find their motion is restricted because they don't have a smooth articulation. So in an arthritic shoulder, the ball is now rough and the socket is rough. And if we're going to do a, quote, anatomical replacement, we're going to replace that roughened ball with a new smooth ball, and we're going to reshape the socket with a smooth socket. So the mechanical problem of osteoarthritis, where the surfaces are rough, has now been treated with smooth surfaces, but they're in the same position and the same shape as the normal shoulder joint before you had surgery. In a reverse replacement, we don't respect that same shape. So where the ball was initially, we now place it with a socket. And where the socket is, we replace that with a ball. And the idea behind that is that if there's asymmetrically wearing of the shoulder because there's muscular imbalance, if you don't address that and you replace that with a ball and a socket like a normal anatomical shoulder, you'll still have that asymmetric wear. It's sort of like the tire in your car. If you don't balance those tires, you're going to wear out asymmetrically, and you really won't be further down finding a solution that you might want. So that's the real difference, and that's why they look slightly different. I'm often asked about how likely is this operation going to help me, and how long will it last? So again, the research that we've been doing here at the Florida Orthopaedic Institute, in conjunction with the Florida Orthopedic Research and Education Foundation, has really tried to provide answers to that. So of the 6,000 shoulder replacements that I've done over the 30 years that I've practiced here in Tampa, we have several thousand patients that we have data before their surgery, data afterwards, and we expect our patients to come back every year. Now, many patients don't, but we have a number of patients that do. And so from that data, we have published our experience in peer-reviewed journals. So when we publish something in a peer-reviewed journal, that means it's the highest level of scrutiny. It's sent out to colleagues around the world who are experts in this field matter, and they look at the scientific method of how we did our studies. Did we use good scientific method? Are our results reproducible? And from those studies, we can say that if you have a reverse shoulder replacement, the likelihood of you having 10 years of having a shoulder that works well with little pain is about 92%. And that was done on patients that were the earliest generation. So we think that our results are probably as good as that currently. We don't know past 10 years because, again, I started doing these operations in '97. There have been many different iterations of that. It was only FDA approved in 2004. So we don't have a lot of patients that have longer than that. But, that's part of why it's an ongoing research. But that gives an idea to someone who has a disability that they can look forward to an improvement that's likely to be fairly durable. Well, whether it'll last them their life, I don't know. But that's a pretty good idea about what they can expect in terms of improvement of comfort and function of their shoulder. And with anatomical replacement, it's probably about the same. We haven't looked so much at that, although we're currently looking at that now, and it looks similar. I've had both of my shoulders replaced. My left shoulder was replaced about 15 years ago. My right shoulder was about a year and a half ago. And as a result, my shoulder pain is diminished. I can do activities now that I couldn't before. I can tie my mask for surgery. I can do overhead exercising. I can sleep comfortable on my shoulders. So overall, my overall health of well-being is substantially improved. Before it'd be hard to put on a coat, it'd be hard to sleep comfortable. Going to put something up in the overhead bin would be a struggle. It would be difficult to accomplish the things I wanted to in a day because my shoulder pain or restrictions would limit me. Shoulder replacement surgery is generally very well tolerated. For example, after my right shoulder replacement, I didn't take any pain medicine, nothing. I didn't have to take Tylenol. It is remarkable. It's very well tolerated. So if you do a rotator cuff surgery, you make small incisions, you do it as an outpatient. So it really lets people, you sort of bait and switch type thing. You do a shoulder replacement, you're in the hospital generally for a day or so, but it's a bigger operation, but it is very well tolerated. Most people after shoulder replacement, they really don't need to do a lot of therapy. We don't send the physical therapy. We have them do exercises that the majority of people can do on their own. Because once you make the joint so it moves smoothly, people can now regain their motion. They don't need a lot of coaching or stretching or those sort of things. So it's very difficult to tell someone exactly what they can do. But you can say, based upon the work that we've done here, it's very likely you will notice a reduction in your shoulder pain, and you'll notice that there's many things you can do now that you couldn't do before, and that's fairly durable. So we don't impose restrictions per se. My left shoulder replacement was done by Dr. Cofield at the Mayo Clinic 15 years ago, and he was the person I studied under. That was my fellowship director when I was getting my education. And then last year, a year and a half ago, Dr. Mighell at the Florida Orthopaedic Institute did my right shoulder, and he was one of my fellows 20 years ago.
My name is Mark Mighell, and I'm a shoulder and elbow specialist at Florida Orthopaedic Institute in Tampa. I came here almost 20 years ago, and my educational background started at the University of Virginia. As a University of Virginia Cavalier, you can imagine that I'm very excited right now because we're now NCAA champions. But besides that, I studied chemistry and languages. I actually speak 6 languages, including Russian, which is my mother's first tongue as a child. When I finished University of Virginia, I went to the University of Maryland School of Medicine in Baltimore, and there I started studying medicine. I became fascinated with anatomy, particularly the anatomy of the extremities. So while a student, I focused on doing research projects and anatomical dissections of the shoulder, elbow, and hand. I had the pleasure of rotating on a service called Shoulder and Elbow, where in fact I saw shoulder replacements. I also saw arthroscopic procedures done for the first time. I was fascinated with the shoulder, and I thought to myself that for me, a career in shoulder and elbow surgery would be more rewarding. I also really liked the patients. Many of the patients who came into the shoulder and elbow clinic were golfers, tennis players, or liked to work out. In this capacity, I was able to meet many wonderful individuals who convinced me that shoulder surgery was my calling. Having decided that, I did a fellowship in shoulder and elbow reconstruction in the Tampa Bay area in 1997, 1998. I did perform procedures as a resident. However, once I became a shoulder and elbow specialist, from 1998 to 2018, it's been over 20 years. So I've had a wealth of experience, and in fact, at this point, I've done over 2,000 primary total shoulders and close to 500 revision arthroplasties for 2,500 surgeries performed. That has to do with shoulder arthroplasty. My other passion is arthroscopy, and for me, arthroscopy is a 3-dimensional kind of challenge where you can fix a rotator cuff and you can do wonderful things to improve stability of shoulders. And then in that field, I've done over 2,000 arthroscopies to repair rotator cuffs and to correct shoulders that are unstable. In addition, I have been working tirelessly to work in terms of producing manuscripts or literature regarding shoulder and elbow problems. And this also has allowed me to join a very prestigious group of shoulder and elbow surgeons called the American Shoulder and Elbow Society. This is a group of like-minded individuals who enjoy improving research and education, and we meet on an annual basis, and every year we meet in a different location. And I've been a member of the American Shoulder and Elbow Society since 2005. In addition to that, I really love my community. I've been involved in my church, Palmacia Presbyterian. I love the local high school, and I have been the team physician at Plant High School for over 10 years. There I've had an opportunity to see many young athletes and treat them when they get injured. And this has been very exciting for me because I really enjoy Friday night football in Florida. In terms of other awards that I've received, I have been nominated to be a board's examiner, meaning that when you become an orthopedic surgeon and you say you are board certified, someone examines you. I'm one of the individuals that they have selected to examine young orthopedic surgeons to determine whether they can in fact become board certified. I've been really involved in shoulder and elbow research and in academics, educating both residents and fellows. I've been part of an accredited fellowship program since 2002. We've trained many fellows who've gone across the United States to continue doing shoulder and elbow surgery. In terms of the peers, my community have been nominated me as Best Doctor in America for over 10 years, since 2007. And I take that as a real tribute because these are other physicians, other orthopedic surgeons in the area who feel that if they have a patient with a real problem, they'd be happy to send that patient to me. One of the things I really wanted to talk to people about is arthritis itself. So arthritis is actually inflammation of the joint that occurs as people get older, and most arthritis is due to aging changes or natural history, but sometimes it's due to an accident or trauma to the shoulder joint. It can be due to prior surgical procedures. And once arthritis starts to set in, what happens is the joint becomes inflamed. It is irritated, so you get pain. And when the joint is inflamed, the fluid in the joint actually changes. So people with arthritis, instead of having a thick lubricant in their shoulder, get a more watery fluid. And as time goes on, the beautiful cartilage cushion inside the joint that takes the shock when you're doing activities starts to wear away, and bits of cartilage can flake off. Sometimes the first presenting complaint is just tenderness or swelling, and usually this occurs in the morning. Oftentimes people wake up and their shoulder is stiff and sore, and they're confused like they did too much. But in fact, what happens is they start using it again, it feels a little bit better. So that tells us that some gentle exercise is always good for patients who have arthritis. So I've found that when people come in, I tell them, you need to hydrate, you need to keep your weight down, you need to continue to be active. Arthritis isn't a disease that makes you slow down. You should continue to do activities you enjoy. By not doing activities, it's going to affect your overall health and other activities you do. One of the things that I always prescribe my patients when they first come in is glucosamine chondroitin sulfate, which helps to stabilize the cartilage. And I think it's nice is that a lot of people are into some of the more natural preparations. So some patients will gravitate towards turmeric, and sometimes you can use turmeric with pepper, which you can get at your local pharmacy or at the grocery store. Other things that are good are perhaps an over-the-counter anti-inflammatory. So for mild arthritis pain, Motrin or ibuprofen is one of the top-selling drugs in America, and that's because so many Americans have arthritis. So taking that is not bad, but if you take it long-term, you have to think about the other things that go along with taking an anti-inflammatory. You can have blood pressure elevation, it can affect your kidneys, you can get ulcers. So you really should consult with a doctor before you take long-term use of anti-inflammatories. This is for early arthritis. Sometimes patients come in and they have no idea they have arthritis, and you get an x-ray and it looks awful, and they say, well, I didn't have arthritis until I fell down. But in fact, that was the final defining moment for their arthritis, the kind of straw that broke the camel's back that led them into the doctor's office. So once you have arthritis, patients are often confused because they don't feel that old, or they don't want to be that old, and they're looking for some answers for treatment. At present, sometimes a cortisone shot can reduce the inflammation, and then we can have them get engaged with a physical therapist to work with your arthritis. If that doesn't work, then sometimes we can start talking about surgical procedures. And a lot of people come to me and they go, I don't understand what a shoulder replacement is. And what's the difference between a reverse shoulder that my neighbor had and a regular or traditional shoulder? And in general, to do a traditional shoulder, you have to have a very, very healthy rotator cuff. You can't have a rotator cuff tear or prior surgery on the rotator cuff. And generally those patients are a little bit more active and younger when I do the total shoulder replacement. So before we ever do a shoulder replacement, we oftentimes will get advanced imaging. And by that I mean either an MRI scan, which people are familiar with, or a CAT scan or CT scan. Now MRIs use magnetic fields, and CT scans are more radiation. So you do get exposed to some radiation, but now we can make three-dimensional reconstructions and kind of reconstruct the diseased joint so we can plan out a surgical procedure. I generally tell people that until their pain is horrible or their bad days outnumber their good days, it's probably better not to have the operation. You want to maximize your own body and maintain your own body until you actually have to have your joint replaced. So for the other type of shoulder replacement, the reverse shoulder, this is a device that was developed for patients who have a deficient rotator cuff. So if you have a rotator cuff tear, you had prior rotator cuff surgery, your joint isn't balanced. The reverse shoulder kind of acts like an artificial rotator cuff and a shoulder replacement. It has more constraint and it allows you to regain function of your arm. So they're quite different operations in the sense that one needs the rotator cuff to be highly efficient, and the other, it's nice to have your rotator cuff, but you don't need it. So these operations, you can consult with either your orthopedic surgeon or myself or another doctor, and we can help to explain this to you in greater detail. Now, what these materials are, a lot of people don't really understand what a joint replacement is, but actually you're just taking off a little bit of the actual joint surface. So even though the implants can look larger, the amount of bone removed is no bigger than a deviled egg. It is a tiny little bit of bone that you take out, and you replace that pitted, corroded, kind of worn out bone with a beautiful cobalt chrome ball. These days, some patients even have allergies to nickel, so we even have all titanium shoulders that are kind of innovative, that have come out that help us to deal with people who have metal allergies. So once you made the decision to have a shoulder replacement, it is something that sometimes can be scary, because if you haven't had a surgery, you can be nervous. One thing I can tell you is that when you have a shoulder replacement, the actual operation, if you go to someone who does over 50 a year, probably takes less than an hour. And you're only going to spend one night in the hospital. And if you're very healthy, you potentially could go home the same day. There's very little blood loss. It's rare to have a blood transfusion, and the success rate is over 95%. So it's a very, very good operation and durable. So most shoulder replacements will last for 15 years. And we've now had data that shows that the reverse shoulder can even last 20 years. So that is a long time for your shoulder replacement to last. And I always tell people the risk of anesthesia, if you don't have severe heart or lung conditions, is the same risk as flying to LA. So it is not a very dangerous operation to have.
I was introduced to a concept called a reverse shoulder replacement in the early 90s by a friend of mine in France who told me that he had had great success with some version of that, but he didn't really understand how it worked. So in 1997, I did my first reverse shoulder replacement. And this is well before anyone in the United States considered doing it. And we had some problems on our early designs, but we continued because we were encouraged by some of the outcomes that we were seeing. And these outcomes now are the standard. They are unbelievable. Is in the shoulder, there's a great deal of mobility, and the mobility occurs by a joint that does not have a lot of constraint. So if you look at the shoulder, it looks like a big ball on a golf tee. And so the way the shoulder stays stable normally is the muscles around the shoulder, they keep it stable. But as we get older, or in some traumatic cases or some degenerative cases, your rotator cuff muscles and tendons may become affected, and now you develop some sort of muscular imbalance. And this imbalance can be quite severe and incapacitating to patients where they can't use their arm to eat, they can't use it to bathe, they can't use it for sporting activities. They have severe pain that limits their ability to rest comfortably. And so it is a significant problem that impedes one's life in terms of the quality of their day-to-day existence. So a reverse replacement provides stability to the joint, and it does so, again, by reversing the articulation. So the things that we've done in our research lab that have led to these breakthroughs have been trying to identify the ideal patient, the ideal prosthetic design, what patients are not maybe so well suited for it, and that has been the last 20 years of our work. And again, it has been really quite gratifying to see that we've made major contributions, that our work has been honored throughout the world. I've been very involved in innovation and been very fortunate to have a group of a manufacturing company and a group of researchers to help me really improve reverse shoulder replacement. Again, it was something I pioneered in the United States, and I continue to strive to improve that surgery by finding the right patient, by having the right implant. So one of the things that has been recent is we realized at some point that we wanted to have a variety of sizes available. So about 5 years ago, it was clear that on the socket side, which is on the ball side of the normal shoulder, we only had one size, and that was a problem. We really needed to have a smaller shell or a smaller socket. So in the last year, we've come out with a smaller socket, and it really has allowed us to treat people far better, especially smaller stature people, women that are generally in that category. So that's been another innovation. And the innovation process, we're continually to strive to make this better. So the future of shoulder replacement is, it's not gonna be, I don't imagine, one big deal. Reverse shoulder replacement was a big deal. That was a big shift. These are now all incremental shifts. We're finding we can do the surgery with less pain. We're finding we can do the surgery quicker and easier. We're finding patient selection a bit better, and we can allow patients to go back to these activity levels, which before we would be reticent to do. So those are the current advancements. I think for the patients who are trying to consider whether or not they should have surgery, I just say, look, if it gets to the point where you notice this every day in your life, and every day in your life you're like, God, this is really impacting me, And if you start thinking, God, if I could have anything for Christmas, what I'd really like is a good shoulder, those are pretty good hints that maybe you should think about getting treatment, because you're likely to find it really helps you. Most of the time when we're trying to decide something, it's often fear that is our biggest impediment. And it's interesting when you look at research on psychology, people will do more to avoid losing $1 than they will to make the same dollar. It's just $1. So we're very fearful, and sometimes we feel that we have to accept things because we're like, well, my life's not that bad. My shoulder hurts me a little bit, but it's not that bad. And if it's truly not that bad, denial of your symptoms is a reasonable coping strategy to no longer it works. So in 2 a.m. when you're waking up and your shoulder's hurting you, just remember that there is a treatment available for you that's safe, it's effective, and it's very likely to help you.